Welcome back to the deep dive. Today, we are immediately plunging into one of the most critical and frankly emotionally charged areas in adult health, the assessment and management of patients with breast disorders.
It really is.
This field isn't just complex clinically, it's a high-stakes emotional area for every single patient involved.
It truly is. Our focus today is to take the dense, comprehensive framework of a foundational medical surgical nursing chapter and, translate it into a clear, accessible guide.
Okay.
The central, non-negotiable lesson for anyone entering this field, especially in nursing, is the dual necessity of care. You have to be an expert in managing the physical reality of the disorder.
Right, the clinical side.
Exactly, whether it's benign or malignant. But you must simultaneously become a skilled guide through the profound psychosocial symptoms. The anxiety, the fear of disfigurement, body image changes, and of course the ultimate fear of death.
That's our mission then. We're providing you with a step-by-step pathway through anatomy, diagnostics, surgical intervention, and systemic treatment. Our goal is for you, the learner, to walk away with quick but thorough expertise in how to synthesize the physical and emotional elements of this incredibly challenging patient journey.
Let's get into it.
To diagnose and treat effectively, we have to start with a firm anatomical foundation. So let's quickly review the basics. Where exactly is this tissue located?
Okay, so the breast structure lies against the chest wall, and it extends roughly between the second and sixth ribs. Laterally, it goes from the sternum all the way across to the mid-axillary line.
And that's a wider area than I think most people realize.
It is. It's not just chest tissue. It's an extensive system, and understanding its boundaries is absolutely key to understanding how a tumor might spread.
And the supporting structures are critical too, right? Because they dictate how the tissue is affected by disease. The source material highlights 3 names we need to lock down immediately.
Exactly. First, there's the tail of Spence. This is a wedge of breast tissue that extends up and out, superiorly and laterally, into the axilla.
Into the armpit area.
Correct. It's crucial because it's a very common pathway for cancer spread and a common location for a tumor to form that can be missed if your assessment isn't thorough.
Okay, tail of Spence. What's number 2?
Second, the Cooper ligaments. These are the fibrous fascial bands that connect the breast to the chest wall. They're like supports. Now, when a malignant tumor grows, it can actually contract these ligaments.
It pulls on them.
It pulls on them, and that's what leads to the classic retraction or dimpling signs we look for during an inspection.
And finally, the inframammary fold, which is just that ridge of fat at the base of the breast defining its contour. Internally, though, it's a whole system.
It is. It's a system of about 12 to 20 cone-shaped lobes, and these are comprised of the glandular elements, the lobules where milk is produced, and then the ducts that transport that milk to the nipple. Almost every malignant process is going to originate within this ductal or lobular system.
That makes sense.
And since this is glandular tissue that matures over time, we should probably touch on the Tanner stages of breast development.
Right.
While there are 5 stages, the key clinical markers for nurses are pretty simple. Stage 1 is prepuberty, but the critical first sign of estrogen influence and the start of puberty is stage 2, breast budding.
So that's the one to watch for.
That's the one. The development progresses from there until stage 5, which is the final adult contour. This just provides necessary context when you're assessing adolescence.
Okay, so now we move into the clinical assessment. Beyond the standard review of systems, the health history here needs to be, well, laser-focused on potential risk multipliers. What are the key nuggets of patient history we have to gather?
You start with the family tree. A detailed family history of breast cancer, including the age at diagnosis for any affected relatives, is absolutely non-negotiable. Then we pivot to the gynecologic and obstetric history. What's fascinating here is how the total lifetime exposure to estrogen dictates risk.
Okay, so how does that translate clinically? Can you break that down?
Think about it this way. The longer the reproductive lifespan, the higher the risk. So early menarche, getting your period before age 12, and late menopause after age 55.
So a longer window.
A longer window. It increases risk because it just extends the duration of hormonal exposure. Similarly, nulliparity, meaning no full-term pregnancies, or being at a late age at first full-term pregnancy, so after age 30.
Why does that matter?
Because the protective differentiation that happens to the breast tissue during a full-term pregnancy occurs later in life, or, not at all.
That's a great way to frame the why for the patient. So beyond the body's own hormones, we also need to document the use of exogenous hormones, right?
Absolutely. Past or current oral contraceptives, hormone therapy or HT for menopause symptoms, or any fertility treatments, and of course the lifestyle factors. Smoking, alcohol consumption, and any history of radiation exposure, especially during adolescence.
And before you even touch the patient.
Before the physical exam, you have to gather specific psychosocial information. You need to know, what is the patient's marital status? What supports do they have? Do they have the resources to even adhere to a complex treatment plan? A diagnosis of a breast disorder, even a benign one, never exists in a vacuum.
So true. Okay, let's unpack the physical inspection. The patient starts seated. We look for size, recognizing that slight asymmetry is normal. But the real skill comes from spotting the key abnormal findings. Let's walk through the visual cues that should trigger immediate concern.
First thing you look for is color changes. Erythema, just redness, could be benign inflammation, sure, but it has to be investigated because it can also signal a superficial lymphatic invasion by a tumor.
Wow, okay.
Another subtle vascular sign is a prominent venous pattern. If it's localized and just on one side, it can indicate the increased blood supply that's required by a growing, often malignant tumor right under the surface.
And here is the one visual sign you must never ever miss. The critical insight that tells you the tumor is advanced. Peau d'ange. It's a French term, means orange peel skin.
It's exactly what it looks like. It's severe edema and pitting of the skin caused by the tumor obstructing the lymphatic drainage system. The skin becomes thick, hard, immobile. This isn't subtle. It's a classic advanced sign, and it often points toward inflammatory breast cancer.
And what about the nipple itself?
We have to examine the nipple. If the nipple is inverted, we need to know, is this a nipple inversion of recent origin?
So is it new?
Is it new? If it is, it suggests an underlying mass is tethering the tissue, pulling it inward, and that is a major red flag for malignancy. If it's been inverted since puberty, that's just a normal variation.
And to really test for that tethering, you need specific maneuvers to expose those retraction signs, the dimpling or creasing.
That's right. We instruct the patient to raise both arms overhead, and then, crucially, to press their hands firmly onto their hips.
To flex the chest muscles.
To contract the pectoral muscles. If that dimpling or contour change only appears when the muscles contract, it strongly suggests a fibrotic mass is tethered deep within the breast tissue.
Okay. And what about the skin of the nipple and areola?
Right. Finally, you look at that skin for Paget disease, which is a malignancy of the ductal system. Early signs are erythema, itching pruritus, and scaling, often mimicking a persistent dermatitis that just won't go away.
So it looks like eczema.
It can, yes.
Yeah.
Later, it progresses to erosion and thickening. We also visually inspect the entire drainage field, the supraclavicular and axillary regions, for any palpable lymph node swelling.
Okay, so that's inspection. Now, transitioning to palpation. For the female patient, we palpate seated and then supine. Why is that specific supine positioning so vital?
Because gravity works against us. When the patient is supine, we place a small pillow under the shoulder corresponding to the breast being examined.
I see.
This elevates the chest wall, and it distributes the breast tissue evenly across the chest. It prevents a potential mass from slipping laterally into the axilla or into the chest wall fold where you can easily miss it.
And technique is paramount here, I assume.
It is. We use the flat pads of the second, third, and fourth fingertips, kept together, moving in small dime-sized circles. And the sources mandate a systematic approach to ensure you cover everything. You can use concentric circles, the clock face pattern, or the highly recommended vertical strip pattern, moving up and down the breast field.
What about the axilla?
For axillary palpation, the patient stays seated. We gently abduct the arm and examine the lymph nodes against the thoracic wall. Normally, these nodes are not palpable at all.
And if they are?
If they are, you're logging size, location, mobility, and consistency immediately.
This is the moment where we gather the major diagnostic clues then. Let's talk about mass characteristics. What is the fundamental difference that dictates whether our clinical alarm bells start ringing?
We are looking for the 3 I's of malignancy: irregular, immobile, fixed, and indurated. Hard.
Okay, say that again.
Irregular, immobile, and indurated. Malignant tumors are typically hard. They have poorly defined or irregular borders. They're fixed to underlying tissue, and they're usually non-tender.
And a benign mass.
Conversely, benign masses, like a simple cyst, are usually well-defined. They feel softer or more elastic. They're easily movable, freely mobile. And they may be tender, especially with hormonal fluctuation.
We can't complete this section without discussing the male patient. Male breast cancer, though rare, often presents late.
It does. Assessment has to be thorough. You're checking for discharge, nodules, or ulcerations. Palpation focuses on that flat disc of undeveloped glandular tissue that's right beneath the nipple.
Which leads us to gynecomastia, the most common condition in men. And nurses have to know the difference here.
They do. You have to distinguish between true gynecomastia, which is a firm, palpable enlargement of the glandular tissue under the areola, and the soft, widespread fatty tissue enlargement that just results from obesity.
And what causes true gynecomastia?
It's often related to hormonal imbalances, certain medications, or underlying conditions like liver disease or Klinefelter syndrome.
Okay, before we leave the fundamentals, let's connect general health to breast cancer risk. The source material draws a really strong link to obesity.
This connection is dose-dependent, and the pathophysiology is key. Adipose tissue, or fat, is metabolically active. In postmenopausal women, when the ovaries stop producing estrogen, fat tissue actually becomes the primary site for estrogen production.
Through what process?
Through the aromatase enzyme. So a high BMI 25 or higher after menopause significantly increases circulating estrogen, which can promote tumor growth. Obesity also creates a pro-inflammatory state in the body, which contributes to atypia.
So the takeaway is clear.
Absolutely. Maintaining a healthy weight is cited as a protective factor against postmenopausal cancer.
Okay, so if our initial assessment raises red flags, we immediately shift from observation to diagnostic confirmation. Let's start with screening and the crucial philosophical shift in approach. The sources emphasize moving away from routine, prescribed BSE, toward breast self-awareness, or BSA.
This is a major public health distinction. BSA just means the woman is attentive to the normal look and feel of her breasts and reports any change to her provider immediately.
Why the shift away from routine BSE?
Because studies showed it didn't significantly improve survival for average-risk women, and actually, it often led to unnecessary anxiety and biopsies from false positives.
So is BSE entirely obsolete then?
Not at all. The source material is clear on this. BSA is the standard for average-risk women, but routine monthly self-examination is still entirely appropriate for high-risk women or, for those who just feel more comfortable performing it.
And if they do choose to perform it, timing is key.
Essential. It should be done 5 to 7 days after menses begins for premenopausal women. That's when the tissue is least nodular and tender. But the universal rule remains. Report any persistent change, regardless of when your last self-exam occurred.
Okay. Now, mammography. It's still the cornerstone of early detection. The American Cancer Society guidelines provide a clear roadmap that nurses must know for patient education.
Yes. The current recommendation is that healthy women should start annual screening at age 45. However, women aged 20 to 44 have the option to start yearly screening early if they choose to.
And what happens after 55?
Once a woman turns 55, she can transition to screening every 2 years, or she can continue with yearly screening. It becomes more of a shared decision.
And that flexibility reflects the careful calculus of modern medicine, doesn't it?
It does. When we start later or screen less often, say every 2 years, we decrease the burden, fewer false positives, less anxiety, less cost.
Yeah.
But we accept the small trade-off of potentially missing an interval cancer and diagnosing a slightly later stage disease. It's a calculated risk-benefit discussion.
And the procedure itself, it involves a lot of compression.
It does. That compression, while uncomfortable, is mandatory because it spreads the tissue evenly, it reduces the radiation dose, and it improves the visibility of abnormalities, especially those tiny microcalcifications.
Yeah.
We use low-dose X-rays taking 2 views, craniocaudal and mediolateral oblique. And you have to reassure patients that the radiation exposure is minimal. It's equivalent to about 7 weeks of natural background radiation.
And technology is improving detection here. We have 3D mammography or tomosynthesis.
Which is fantastic. It provides multi-layered projections, which significantly improves visualization, especially in dense breasts, and it leads to lower false positive rates. And we also have CAD, or computer-aided detection, which is software that flags suspicious areas for the radiologist to double-check.
So if the mammogram is suspicious, or if the patient has specific symptoms, we move to adjunct imaging. What if a patient presents with spontaneous or bloody nipple discharge?
Then we'd use a contrast mammography, which is also called a ductogram or galactogram. This involves injecting a radiopaque dye directly into the duct opening to visualize what's going on inside the duct. It's often an intraductal papilloma.
And ultrasonography, that's a huge tool.
It is. It's fantastic, especially for younger women with dense breast tissue or for clarifying findings on a mammogram. It's quick, there's no radiation, and it is brilliant at one specific thing, distinguishing a fluid-filled cyst from a solid mass.
But it has limitations.
It has a critical limitation. Ultrasound cannot rule out malignancy on its own because it can't visualize microcalcifications, which are often the earliest radiographic sign of cancer. So it's an adjunct, not a replacement for mammography.
Then there is magnetic resonance imaging, or MRI. This is the heavy hitter for high-risk screening.
It is. It's recommended for women with a lifetime risk greater than 20% known BRCA mutations or a history of chest radiation. It is highly sensitive, it requires an IV gadolinium contrast, and the patient lies prone.
And there's a crucial nursing safety alert regarding MRIs that we just cannot overstate.
Absolutely. Because of the powerful magnet, the procedure is contraindicated if the patient has most types of implantable metal devices, things like the metal port in a temporary tissue expander, or certain aneurysm clips.
What about medication patches?
Yes. Any external medication patches, especially those foil-backed ones like nitroglycerin or fentanyl, must be removed before the procedure to prevent severe skin burns.
Okay, so a key concept alert here. Mammography detects, but the biopsy confirms. We move now to the procedures that provide a definitive diagnosis. How do we categorize them?
We could differentiate between the outpatient, less invasive percutaneous biopsies and the more formal surgical procedures.
Let's start with the simplest.
The simplest, quickest needle biopsy is the fine needle aspiration, or FNA. It uses a very small 20 to 27 gauge needle to remove cellular material.
And what happens to that material?
Well, if the aspirate is fluid from a simple cyst, the fluid is usually just discarded, as the cyst itself is often relieved by the aspiration. But if the fluid is bloody, that is highly suspicious, and it must be sent for cytology.
What's the risk with FNA?
The risk is that FNA only provides cells, not tissue architecture. So you have a higher risk of false negative or false positive results if the sample wasn't perfectly representative.
And that risk is mitigated by the core needle biopsy.
Exactly. This uses a larger 11 to 18 gauge needle to remove actual tissue cores. This gives the pathologist the tissue architecture they need for a definitive diagnosis and for receptor testing. It's often guided by ultrasound.
And what about for lesions you can't feel? Things like suspicious microcalcifications you only see on a mammogram.
For those non-palpable lesions, we use the highly technical stereotactic core biopsy. The patient lies prone on a dedicated table, the breast is compressed, and a computer pinpoints the precise coordinates to guide the core needle.
And there's a key detail here about a clip being placed.
Yes, crucially, at the end of this procedure, a small titanium clip is almost always placed at the biopsy site. This is so the site can be located again in the future, should treatment be required.
And we need to reassure the patient about this clip.
You do. You tell them this clip is tiny, it's inert, and it does not preclude future MRIs or trigger airport scanners. It's perfectly safe.
Okay. And what if the lesion is only visible on an MRI or ultrasound?
Then we use ultrasound-guided or MRI-guided core biopsies. Finally, if the tumor is large or for definitive removal of a palpable lesion, we move to surgical biopsy.
And there are two types there.
Right. An excisional biopsy, which is a lumpectomy, removes the entire mass plus a margin of surrounding normal tissue. An incisional biopsy removes only a portion and is usually reserved for very large tumors to confirm the diagnosis before starting chemo.
What if you need to do a surgical excision on something you can't feel?
That's where the radiologist assists using wire needle localization. A wire is literally threaded right into the lesion under imaging guidance, and then the surgeon uses that wire as a roadmap to excise the exact tissue required in the operating room.
So the nurse's role pre- and post-biopsy is huge. It's focused on safety, anxiety management, and education.
Absolutely. You have to assess anxiety and provide a clear step-by-step explanation of the procedure, whether it's a quick FNA or a more involved stereotactic procedure.
Safety-wise, before any biopsy, we have to ensure the patient has discontinued agents that increase the risk of bleeding. This is a common point of confusion for patients.
It is. The list includes aspirin, antihistamines like ibuprofen, high-dose vitamin E supplements, and herbal remedies like ginkgo biloba and garlic.
And what about prescription blood thinners?
If they are on prescription anticoagulants like warfarin, they must clear temporary cessation with their prescribing provider. That's not a nursing decision.
Got it. And post-procedure?
We monitor for bleeding and pain. Pain is usually managed well with acetaminophen. The discharge teaching for wound care is very specific. The main dressing comes off after 48 hours, but the tiny butterfly strips, the steri strips, must stay in place for 7 to 10 days or until they fall off on their own.
Activity restriction is also important. They should wear a supportive bra for comfort and avoid jarring activities, strenuous exercise, or heavy lifting for about a week.
Right, to allow the tissue to heal. And perhaps most critically, the nurse is the bridge. If that pathology report comes back positive for cancer, the nursing role shifts dramatically from simple wound care to complex treatment planning support.
A huge shift. Before we dive into malignancy, though, we have to master the common, non-cancerous conditions that cause so much anxiety. Let's start with the nipple. Nipple discharge is one of the most common complaints.
It is, and while it's concerning for the patient, it is usually benign.
So what makes a discharge concerning? Because clear or milky discharge when you express it can be normal for up to a third of women.
That's right. The critical characteristics that sound the alarm are discharge that is spontaneous, persistent, unilateral, or, most significantly, bloody.
And bloody discharge must be cancer, right?
Surprisingly, no. Bloody discharge is often due to an intraductal papilloma, a benign wart-like growth inside the duct rather than cancer. But it must always be evaluated with a guaiac test for occult blood or a galactogram.
Okay. Moving to infection, the most common is mastitis, typically seen in lactating women.
Yes. The tissue feels tough and doughy, and the patient will present with dull to severe pain and systemic symptoms like fever. Treatment is a 7 to 10-day course of broad-spectrum antibiotics, cold compresses, a snug bra, and rest and hydration.
And if it's not treated?
If it's untreated or persistent, it can progress to a lactational abscess, which requires aspiration or incision and drainage, plus culture-specific antibiotics.
Now, what about the most common complaint in the clinic, which is pain or mastalgia?
The crucial counseling point for the patient here is that pain is rarely indicative of cancer. It's usually cyclical, related to hormonal fluctuations, or non-cyclical, related to trauma or biopsy recovery.
And how do we manage that pain?
The management plan is non-pharmacological first. A supportive bra worn day and night, no underwire. Dietary modifications like decreasing salt and caffeine intake, and OTC relief like ibuprofen. Some patients also find relief with vitamin E supplements.
Next up, cysts or fibrocystic changes.
Right. These are fluid-filled sacs, common in women 30 to 55, that fluctuate in size and tenderness just before menses. The term fibrocystic changes itself is a broad, non-disease category that just encompasses normal lumpiness and tenderness.
And aspiration can help.
Aspiration, or FNA, can both diagnose the cyst and often relieve the pressure and pain at the same time.
Okay, so to distinguish these common benign findings, we rely on the comparative characteristics. Let's contrast the three major types of lumps we might feel.
Let's do it. First, cysts. Usually in women age 30-55, soft to firm consistency, highly mobile, often tender, and they usually disappear after menopause.
Okay.
Second, fibroadenomas. Usually from puberty to menopause, typically firm, round, or disc-shaped, highly mobile, often described as feeling like a rubbery marble, and usually non-tender.
And then malignancy.
Peak age is 40-80, usually a single lump, hard or firm, with an irregular or stellate shape, and critically, it's fixed. It's immobile, attached to the surrounding tissue. This clinical picture drives immediate further diagnostic steps.
Finally, we have to discuss benign proliferative breast disease, which, despite the word benign, signifies a significant increase in future cancer risk. These are precursor states.
Yes, and these patients require rigorous surveillance. Atypical hyperplasia, either ductal or lobular, is a premalignant lesion. It elevates cancer risk fourfold.
And even more concerning is lobular carcinoma in situ, or LCIS.
Right. Despite the name, it is not truly cancer. It's an incidental microscopic finding that indicates a 4 to 10-fold increased risk of developing invasive cancer in either breast.
So the nursing intervention here shifts immediately from simple monitoring to active surveillance.
Absolutely. Rigorous surveillance includes annual mammography, potentially an annual MRI if they meet that 20% lifetime risk, and clinical breast exams every 6 months. Crucially, these women are candidates for chemoprevention.
Which means starting anti-estrogen therapy.
Exactly, like tamoxifen, which can reduce their risk by up to 50%.
And now we enter the high-stakes world of malignant disease. For women, the lifetime risk is about 1 in 8, or 12%.
It is. In the majority of cases, 2/3 of them occur in women age 55 or older.
And we have to acknowledge the disparities cited in the literature here.
You do. Non-Hispanic African-American women have a higher incidence of breast cancer before age 40, and tragically have higher mortality rates at every age. This is largely attributed to diagnosis at a later stage and potentially poorer stage-specific survival.
Let's categorize the cancers, starting with invasiveness.
Okay, so ductal carcinoma in situ, or DCIS, is non-invasive. It's stage 0. The cells are malignant, but they are confined entirely within the milk ducts. They haven't broken through the basement membrane.
And the good news there.
The positive side is that DCIS is not metastatic. and breast conservation surgery plus radiation is generally curative. But, and this is a big but, if it's untreated, it has a significant risk, up to 53% over 10 years, of progressing to invasive cancer.
And it's often found just on a mammogram.
Frequently, yes, as microcalcifications.
So once the cells break through the membrane, the cancer becomes invasive.
And the vast majority, 70 to 80% of all cases, is infiltrating ductal carcinoma. It arises from the duct system, it forms a solid, hard, irregular mass, and it spreads into the surrounding tissue.
And the second major type?
The second is infiltrating lobular carcinoma, about 10 to 15%, arising from the lobules. It's distinct because it often presents as an ill-defined thickening rather than a firm lump.
And it has a tendency to be multicentric.
Yes, popping up in different spots in the same breast, and it's often bilateral.
And then there is the rare but highly aggressive inflammatory carcinoma.
Only 1 to 5% of cases. But it's the malignancy that presents with that dramatic peau d'orange, the diffuse edema and erythema, because the malignant cells have rapidly blocked the dermal lymph channels.
And because it looks like an infection, it can be misdiagnosed.
It can, so nurses must ensure a rapid diagnostic workup, and the treatment is different. It requires chemotherapy before any surgery.
Okay. When we counsel patients, risk factors fall into categories. Let's start with the non-modifiable ones.
The ones you can't change are simply female gender and increasing age.
Then we have genetic risk.
That's right. The BRCA1 and BRCA2 mutations account for most inherited cases. They can confer up to a 70% lifetime risk for women, and BRCA2 also significantly increases the risk for men. We also include a history of benign proliferative disease like LCIS or atypical hyperplasia here, as they are established precursors.
And the hormonal risks are all related to total estrogen exposure time.
Correct. We already mentioned early menarche and late menopause. You can add to that nulliparity and a late age at first full-term pregnancy after age 30. And critically, current or recent use of combined postmenopausal hormone therapy elevates risk and must be closely reviewed.
The environmental and lifestyle factors are where intervention is possible.
Exactly. We see increased risk tied to adolescent exposure to ionizing radiation, postmenopausal obesity, which we talked about, and daily alcohol intake. 2 to 5 drinks daily can increase risk about 1.5 times.
And we must be prepared to dispel misinformation.
We must. The sources explicitly state there is no credible evidence linking silicone implants, antiperspirants, underwire bras, or abortion to an increased risk of breast cancer. This is a common anxiety point we can confidently reassure patients about.
On the positive side, what helps reduce risk?
The protective factors are breastfeeding for at least 1 year, regular, moderate physical activity, and maintaining a healthy body weight. What links them? They generally work to reduce overall estrogen exposure or inflammation.
For patients identified as high-risk like BRCA carriers, prevention strategies must be formalized and rigorous.
They must. Long-term surveillance starts early, often by age 25. It requires an annual MRI in addition to a yearly mammogram, plus clinical breast exams twice a year. This dual imaging is necessary because of the rapid growth of many hereditary cancers.
Then we discuss chemoprevention.
The most common agent is tamoxifen, a SERM, which is FDA approved to reduce risk by up to 50%. It's generally preferred for premenopausal high-risk women.
And for postmenopausal women.
For postmenopausal high-risk women, aromatase inhibitors like anastrozole or exemestane are the preferred option.
The ultimate preventative measure is prophylactic mastectomy, which reduces risk by 90 to 95%.
It does, but it requires extensive counseling. The physical risk reduction has to be weighed against the massive psychological and body image changes. It's typically done with immediate reconstruction.
Okay, moving from diagnosis to treatment planning. Where do tumors most commonly appear?
The most common location for palpable tumors is the upper outer quadrant. That's just where the largest volume of glandular tissue is found. Lesions that present late often show skin dimpling, retraction, or even ulceration.
Once cancer is confirmed, the immediate question is staging.
Right. We use the TNM system tumor size, node involvement, and metastasis to classify the disease. Staging requires thorough testing, chest X-ray, CT, or MRI scans, bone scans to check for distant spread, and blood work, including tumor markers.
And the prognosis, the patient's outlook, hinges on a few critical factors. What are the two most important?
The two most important are the tumor size and whether there is spread to the axillary lymph nodes. Smaller tumors and negative nodes mean a much better outlook.
What about hormone receptors?
Tumors that are estrogen receptor, ER, and progesterone receptor, PR positive, have a significantly more favorable prognosis.
Why is that?
Because they are responsive to hormonal therapy, which is often less toxic and more effective long-term than chemotherapy.
Conversely, we have the aggressive marker, HER2/neu amplification.
Right. It's overexpressed in about 20% of invasive breast cancers, and it indicates a rapidly growing aggressive tumor and a poorer prognosis, unless targeted therapy is successfully deployed.
And where does it tend to metastasize?
Distant metastasis most commonly occurs in the bone, followed by the lung, liver, and brain. The 5-year survival rate drops dramatically from approximately 88% for stage I to about 15% for stage 4.
So let's talk surgical management. The goal is local control with an emphasis on breast conservation whenever possible.
It is. The most extensive procedure used for invasive cancer is the modified radical mastectomy. This removes the entire breast tissue, the nipple areola complex, and includes an axillary lymph node dissection, ALND. But critically, the pectoralis muscles remain intact.
Which is a huge deal for function and appearance.
A huge deal. For non-invasive cancers like DCIS or for prophylactic surgery, we might use a total mastectomy or simple mastectomy, which removes the breast and nipple areola complex without that extensive ALND.
And the preferred option, if possible, is breast conservation treatment or BCT, a lumpectomy.
Right. The goal is complete excision with a clear margin and an acceptable cosmetic result. But BCT must be followed by radiation therapy to clean up any microscopic residual cells. And if the tumor is invasive, it still requires lymph node removal.
Which brings us to lymph node procedures. Assessing the nodes is foundational for staging. For decades, the standard was the axillary lymph node dissection, ALND, but the morbidity associated with it is immense.
It's huge. The high risk of lymphedema, somewhere between 11 and 57% cellulitis, and long-term neuropathic pain is precisely why the Sentinel Lymph Node Biopsy, SLNB, became the standard of care for early-stage disease.
So it's a targeted approach.
Exactly. It's just as accurate for staging, but it's drastically less invasive. The surgeon injects either a radioisotope, a blue dye, or both, which travels to the sentinel node, the very first node draining the tumor. The surgeon then uses a probe to locate this sentinel node and removes only 1 or 2 nodes, not the entire basin.
And you have to counsel the patient about that blue dye.
You do. The patient must be told that the blue dye can cause a temporary, startling blue-green discoloration of the urine and stool for up to 24 hours.
And the decision about further surgery happens right then in the OR.
It does. If the sentinel node is negative for cancer on the frozen section analysis, the surgeon stops and the patient avoids the morbid ALND. If it's positive, the surgeon may proceed immediately with the full dissection.
The advantages of SLNV are clinical gold. Shorter OR time, less anesthesia, usually no drain.
And most importantly, a minimal risk of lymphedema, up to about 7%. But the post-SLNB nursing management is still vital for psychosocial support, because even if the physical recovery is quick, the patient is still grappling with a cancer diagnosis.
The nursing process really begins the moment that patient receives a confirmed diagnosis. Preoperatively, our assessment is dominated by their psychological reaction.
Absolutely. What are their coping mechanisms, how supportive is their family, and what are their educational needs? The key preoperative nursing diagnoses all revolve around that psychological burden.
So things like anxiety and fear.
Anxiety, fear related to the cancer, the surgery, the unknown, changes to their body image. And you also have to address decisional conflict, because patients are weighing major life-altering choices. Breast conservation plus 5 weeks of radiation versus mastectomy.
So our job is to be the educator and the emotional anchor.
It is. We reinforce the surgeon's explanation of treatment options. We prepare them for the realities of the post-op phase. That drains will be placed after mastectomy or ALND, that their arm mobility will be temporarily decreased, and that they will need to do daily range of motion exercises.
Reducing fear requires setting realistic expectations. We can promote decision-making by clarifying their core values.
You should use direct, focused questions. What is your greatest fear about this procedure? Or, are you willing to commit to the long-term, daily radiation required for lumpectomy? And then you support their final decision wholeheartedly.
Okay, post-operatively, our focus shifts to minimizing pain, preserving function, and promoting adaptation.
Right. Key diagnoses are acute pain, risk for impaired function, and of course, disturbed body image.
Let's discuss pain and those nerve sensations, which is often where patients get confused.
It is. While mild pain is common, moderate to severe pain, especially after the first few days, requires investigation to rule out a hematoma or infection. Acetaminophen or mild opioids are usually sufficient.
But what's often equally upsetting are the postoperative sensations from nerve irritation.
Yes, we have to prepare patients for this. The tenderness, The constant feeling of tightness or pulling across the chest wall, the numbness down the arm. And after a mastectomy, patients may experience phantom sensations, the feeling that the breast or nipple is still there.
And reassurance is paramount.
It is. You have to tell them. These are normal, expected pulses of nerve healing, and they can persist for months or even years.
Promoting a positive body image is perhaps the most sensitive part of the immediate post-op period.
The nurse controls the environment here. We ensure privacy. We assess the patient's readiness before the first dressing change or incision viewing. We acknowledge the profound sense of loss and grief. And if the patient doesn't have immediate reconstruction, providing a temporary soft padding or breast form before discharge helps them feel more balanced and less self-conscious.
And we have to address changes in sexual function.
Directly. Anxiety, fatigue from surgery and treatment, and body image concerns commonly lead to decreased libido. We have to normalize this conversation, encourage open dialogue with partners, and suggest alternative times or positions. Counseling referrals are key if the issues persist.
Now let's turn to the complication that requires lifelong nursing vigilance, lymphedema.
This chronic swelling is caused by the accumulation of protein-rich fluid in the arm when lymphatic circulation is interrupted by lymph node removal or radiation. The risk is high after an ALND, but thankfully low after an SLNB.
This is a lifelong teaching moment for nurses. We have to drill the hand and arm care precautions into every patient.
For the rest of their lives, they must avoid blood pressures, injections, and blood draws in the affected arm. This is a safety rule that protects the compromised lymphatics from injury or infection.
And what are some other specific actions for prevention?
Always use high SPF sunscreen and insect repellent outside. Wear gloves for gardening or using strong chemicals. Use an electric razor for shaving the armpit to avoid nicks. And, most importantly, avoid lifting more than 5 to 10 pounds. Use the arm for exercise, not for heavy lifting.
And if trauma or a skin break occurs, what's the action plan?
Critical action plan. Wash the area immediately, apply antibacterial ointment, and call the provider right away if they notice redness, swelling, fever, or any signs of cellulitis. Infection is a major risk factor for triggering or worsening lymphedema.
And for established lymphedema?
Management includes professional manual lymph drainage, compression garments, elevation, and antibiotics if cellulitis occurs. And it's fascinating that nursing research cited in the chapter indicates that yoga is safe and feasible and may even help improve arm volume and shoulder range of motion.
Other complications include hematoma and seroma.
Right. A hematoma is a collection of blood, usually presenting quickly, within 12 hours, with swelling and tightness. The surgeon needs to be notified for potential evacuation. A seroma is a collection of serous fluid, more common, often occurring after drains are removed. It causes a feeling of sloshing or heaviness. They often self-resolve, but may require aspiration.
Transition to home requires comprehensive education, particularly if surgical drains are in place.
Yes. We have to ensure the patient and caregiver can demonstrate competency in managing the drain, specifically how to empty and measure the output and how to milk clots through the tubing to maintain patency.
And the critical sign for drain removal.
The output has to be consistently less than 30 millimeters over 2 consecutive 24-hour periods. General activity restrictions include avoiding heavy lifting for 4 to 6 weeks. Showering is usually permitted on post-op day 2, but deodorant can only be resumed after the incision has healed.
Finally, the cornerstone of functional recovery is the arm exercises.
Non-negotiable. They are essential for restoring ROM and preventing frozen shoulder or contractures. They begin on post-op day 2 and must be performed 3 times a day for 20 minutes until full range of motion is achieved, which can take 4 to 6 weeks.
And taking an analgesic before can help.
Taking an analgesic 30 minutes before exercising can greatly improve adherence.
Let's detail those exercises as they are crucial teaching points.
Okay. First, wall hand climbing. Standing facing the wall, the patient walks their fingers up the wall as high as possible. Using the wall for support, then slowly walks them back down. Second, rod or broomstick lifting. Holding a stick horizontally, the patient raises it straight overhead, stretching the arms and shoulders.
Third and fourth.
Third is rope turning, tying a rope to a doorknob and using the affected arm to make wide circular swings. And fourth is pulley tugging, using a rope tossed over a shower rod, grasping both ends, and using the unaffected arm to pull the affected arm gently up in a seesaw motion.
This functional recovery continues into long-term follow-up, which is frequent every 3 to 6 months initially.
And we must continually reinforce the importance of screening, especially the mammogram on the remaining breast.
Okay, now systemic treatments. These are used to clean up microscopic disease. radiation therapy is typically used after a lumpectomy.
Yes, to eradicate residual cells and reduce the local recurrence rate. This provides a survival rate that's equivalent to a mastectomy. We use external beam radiation most commonly, 5 days a week for 5 to 6 weeks, often with a boost dose, specifically targeting the tumor bed.
And there's a more advanced option, brachytherapy.
Yes, internal implants, which delivers radiation over only 4 to 5 days. This significantly improves the patient's quality of life and convenience.
And the nursing intervention here focuses on skin integrity.
It does. Acute side effects are erythema, mild edema, and fatigue. We have to teach meticulous skincare. Use only mild, non-perfumed soaps and lotions prescribed by the oncologist. Avoid rubbing, tight clothing, extreme temperatures, and ensure lifelong use of high SPF sunscreen on the irradiated area.
Now, chemotherapy.
Adjuvant chemotherapy is used after surgery for patients with higher risk, generally positive lymph nodes or tumors greater than 1 centimeter to prevent recurrence. It can also be used before surgery, which is neoadjuvant, to shrink a large tumor, potentially allowing a patient to become a candidate for BCT.
Regimens often combine drugs.
They do, called polychemotherapy. We also see dose-dense chemotherapy, where drugs are given at shorter intervals, often supported by growth factors, to target cells during their rapid growth phase. This is a standard of care for many aggressive tumors.
And the side effects are systemic and require comprehensive nursing management.
They do. For nausea and vomiting, we teach proactive scheduling of antiemetics. The triple regimen of 5-HT3 antagonists, NK1 antagonists, and steroids. Patients should take them before symptoms start.
What about bone marrow suppression?
That's a major concern. For neutropenia, we teach patients how to self-inject filgrastim or pegfilgrastim to stimulate white cell production. For anemia, epoetin alpha may be used.
And for the painful mouth sores, mucositis.
Saline, or sodium bicarbonate rinses, a soft toothbrush, and avoiding hot or spicy foods. And for alopecia, which is often the most emotionally devastating side effect, we encourage patients to select wigs or scarves before the hair loss occurs.
Okay, hormonal therapy. This is the primary long-term intervention for the 60 to 70% of tumors that are hormone receptor positive.
That's right. The cornerstone for premenopausal women is tamoxifen, a selective estrogen receptor modulator, or SERM. It works 2 ways. It's antagonistic. It blocks estrogen in the breast tissue, stopping tumor growth. But it's agonistic. It mimics estrogen in bone and lipids, offering protection against osteoporosis.
However, we have to counsel on its serious trade-offs.
We do. Tamoxifen increases the risk of endometrial cancer and, critically, thromboembolic events like DVT or PE. Common side effects include hot flashes, vaginal changes, and mood disturbances.
And for postmenopausal women, the go-to is aromatase inhibitors, or AIs.
Generally, yes. Anastrozole, letrozole, exemestane. They're superior. They work by blocking the aromatase enzyme, which converts androgens into estrogen in peripheral fat tissue. Since postmenopausal women rely entirely on this peripheral production, AIs effectively starve the tumor of estrogen.
But the trade-off for AIs is different.
It is. They're associated with severe musculoskeletal symptoms, arthralgia, myalgia, and because they stop estrogen production entirely, they increase the risk of osteoporosis and fractures.
So nursing management is essential for adherence to these long-term medications.
Absolutely. For hot flashes, suggest layered clothing, breathing techniques. For vaginal dryness, recommend moisturizers or lubricants. For musculoskeletal pain from AIs, suggest non-steroidal analgesics and warm baths. And the safety alerts are crucial. Teach women on tamoxifen to report any irregular vaginal bleeding or leg swelling, and teach women on AIs to ensure they get regular bone density screening.
What about targeted therapy?
Targeted therapy offers precise intervention against specific cellular markers. The most famous example is trastuzumab, a monoclonal antibody used against the aggressive 20% of tumors that overexpress the ATR2 protein.
And how does it work?
It works by binding to that protein, inactivating it, and slowing tumor growth while sparing normal cells. But a major safety alert is required. Trastuzumab carries a risk of cardiotoxicity, especially if the patient has previously received anthracycline-based chemo, which is also cardiotoxic. Cardiac function has to be monitored closely.
And if the disease returns?
If the disease returns locally, regionally, or distantly, the focus shifts from cure to disease control and optimizing quality of life. Treatment involves highly individualized regimens.
So the nursing role is predominantly supportive.
It is, helping the patient and family adjust coping strategies, manage symptoms, and ensuring timely referrals for palliative care and hospice services when it's appropriate.
Let's talk about breast reconstruction. It offers tremendous psychological benefit.
It does, allowing patients to regain a sense of wholeness. It's important to emphasize that reconstruction does not affect the chance of recurrence, and the choice between immediate or delayed timing is often dictated by whether radiation therapy is required. Delayed is preferred if radiation is planned.
The simplest method uses the tissue expander implant.
Correct. A temporary balloon expander is placed under the pectoral muscle and gradually inflated with saline over several weeks to stretch the skin. Then, it's swapped for a permanent implant.
And the nursing safety alert here relates back to MRI.
Exactly. While that expander is in place, the metal port used for inflation means the patient cannot undergo an MRI. Later, the patient must avoid developing the pectoralis muscle excessively, as this can distort the look of the permanent implant.
For a more natural result, patients may opt for tissue transfer procedures using their own tissue.
Yes. The most common is the tram flap, which takes tissue from the abdomen. This is major surgery. It requires 6 to 8 weeks of recovery and carries a higher risk of complications like flap necrosis.
And the post-tram nursing care is very specific.
It is. We have to elevate the head of the bed 45 degrees and flex the patient's knees to reduce tension on that abdominal incision. And they must strictly avoid lifting more than 5 to 10 pounds for 6 to 8 weeks.
What about the nipple and areola?
Once the breast mound is stabilized, a minor outpatient procedure creates the nipple areola reconstruction, often using tattooing or micropigmentation for color.
For patients who choose not to undergo surgery or who aren't candidates, an external prosthesis is vital.
Yes. These forms, usually silicone, help restore balance, assist posture, and provide significant psychological comfort. Nurses ensure the patient receives a temporary lightweight form until the incision is fully healed.
Let's touch on some special issues. Genetic testing, BRCA12.
This requires mandatory counseling because of the heavy psychosocial and ethical weight of the results. Patients experience anxiety, confusion, and sometimes survivor's guilt. They have to understand that testing positive for the mutation doesn't guarantee cancer due to incomplete penetrance.
And pregnancy and breast cancer presents enormous challenges.
It does. Ultrasound is the preferred diagnostic imaging. If diagnosed while breastfeeding, the woman has to stop immediately to allow breast involution before surgery. Treatment often favors modified radical mastectomy, since radiation is contraindicated during pregnancy.
And chemotherapy.
Chemotherapy is carefully timed and sometimes requires termination of the pregnancy if aggressive disease is found very early.
We have to address fertility issues and survivorship.
We do. Chemotherapy often causes ovarian toxicity, leading to early menopause or chemotherapy-induced amenorrhea. Nurses have a critical role in ensuring these young patients are informed about fertility preservation options before starting their treatment. It greatly impacts their long-term quality of life.
And finally, the long-term effects of survivorship.
Patients often experience chemo-brain-impaired cognition, chronic cardiac effects, neuropathy, and persistent psychosocial issues, including a constant fear of recurrence. Nurses must encourage an active lifestyle, weight management, and address these issues head-on.
A final circle back to the male patient. Gynecomastia is most common and usually benign.
It is. Male breast cancer is rare, about 1 in 1,000 lifetime risk, but it often presents late, resulting in a higher stage at diagnosis. It is strongly associated with the BRCA2 mutation.
And treatment is typically a total mastectomy with lymph node removal.
Yes, and since male breast cancers are overwhelmingly ER-positive, tamoxifen is a critical mainstay of treatment. Nurses have to be sensitive to the considerable stigma and emotional distress associated with this diagnosis, which can often lead to poor treatment adherence.
Wow. We have just synthesized an incredibly complex body of work. To recap, we covered the 3 major pillars of expert breast disorder management. First, early detection. Prioritizing breast self-awareness, mastering the visual cues like peau d'orange, and knowing the distinction between core needle and surgical biopsies.
Second, we explored the multidisciplinary treatment landscape, that crucial shift from ALMD to SLMB to preserve function, and the nuanced understanding of systemic therapies, contrasting the competing risks of tamoxifen versus the aromatase inhibitors.
Third, and most centrally, was the role of the nurse in managing the entire patient journey. From guiding patients through decisional conflict and disturbed body image to meticulous drain management and providing lifelong critical education on lymphedema prevention and those restorative ROM exercises.
That's right. Effective breast care requires synthesizing advanced clinical expertise with deep, focused compassion.
Absolutely.
Given the increasing number of long-term survivors and the chronic challenges they now face, including issues like persistent lymphedema, hormonal side effects, and chemobrain, the question we want to leave you with, the question for the future of nursing care, is this. How must the nursing role evolve to systematically integrate rehabilitation and quality of life interventions, such as incorporating advanced fertility counseling, yoga, and robust psychosocial support into standard cancer care protocols to truly optimize long-term survivorship?
A truly profound thought to carry forward into your practice. Thank you for joining us for this crucial deep dive into breast disorder management. We hope you feel ready to provide expert, compassionate care.